Doctors with disabilities exist in small but measurable numbers. How did they navigate their journey? What were the challenges? What are the benefits to patients and to their peers? What can we learn from their experiences? My name is Lisa Meeks, and I'm thrilled to bring you the Docs with Disabilities podcast. Join me as I interview docs, nurses, psychologists, OTs, PTs, pharmacists, dentists, and the list goes on. I'll also be interviewing the researchers and policymakers that ensure medicine remains an equal opportunity profession.
Hello, and welcome back to the Docs with Disabilities podcast. In today's episode, we are joined by Dr. Conrad Addison. Dr. Addison recently completed a sleep medicine fellowship at the University of Utah and is now practicing as a sleep medicine physician in Billings, Montana. In this episode, he and Dr. Meeks explore the experiences Dr. Addison faced when resuming his medical training with the newly acquired disability. They weigh the challenges and values of inviting others to take part in this process and discuss the accommodations that he sought out along the way. We begin with an introduction from Dr. Addison.
Hello, my name is Conrad Addison. I am a newly minted sleep medicine physician. I'm originally kind of from Montana and was attending the University of Washington School of Medicine in my third year of medical school, right at the end, near times for sub-internships and thinking about getting applications together for residency. I had a mountain biking accident and I sustained a cervical spinal cord injury, which left me with a pretty significant mobility impairment. I was able to finish medical school and pursued a residency in internal medicine and then a fellowship in sleep medicine. And I currently am practicing as of last week in Billings, Montana at the Billings Clinic.
Thank you so much for joining us today. And this is such a unique experience for me because I first learned about you when a journal approached me about writing a commentary about a case study that had been published about your case. And I was so intrigued by that case study and about the creativity that was displayed in making sure that you were able to complete your medical school requirements. So I'm so excited to have the opportunity to chat with you today a little bit more and dig a little bit deeper into your experience and what we can learn from it. I'm going to start with following the accident. I know that you took some time off from school. Tell me about going back into medical school. What were you thinking? What were your concerns? And how did you approach the conversations about re-entering medicine as a wheelchair user?
I would say that story actually begins in the intensive care unit. So it was Memorial Day weekend. I had left doing some mountain biking in northern Washington. You end up getting life flighted back to the institution that you just left on a sub-internship, which is a strange experience in itself. But in that, word gets out. And I think a lot of students, a lot of mentors, a lot of physicians were very kind, came to visit. And at that time, I may have been listing on the waves of a propofol delirium. But actually, the CEO of UW Medicine came, visited, said, if you want to go back, we're going to make it happen. This will be something you can do, which was so far away from my reality. But I think in hindsight, it was very appreciated. And a lot of physician mentors kind of had similar messaging in that first month in the hospital of, this is possible, we can get you through, we can help, we can advocate. It kind of just left me with this sense of peace that I can maybe take some time off. I can go focus on finding a new normal, as much as I hate that phrase, but reestablishing my life and really focusing on recovery. And so I did. I spent about 2 months in the hospital. I then really pursued physical therapies, other therapies, really aggressively trying to gain as much function as I could. And I do think it's helpful. So I had a high cervical injury, so I was able to regain some mobility in my shoulders, biceps, but I really have no hand function other than what I can manipulate through those muscle groups. So a lot of this was figuring out what are things I'm capable of doing day to day, what am I not capable of doing. And about 6 months after the injury, I realized that my recovery was maybe plateauing and I could keep throwing myself into therapies, but in order to maybe prevent this accident from becoming a catastrophe, I really needed to find a way to move on with my life and find a vocation, find meaning. And that was the time where, even though I didn't know what it would look like, I felt like, okay, I should get this process started. And I don't know if I want to do clinical medicine. I don't know if that's a possibility even at this time. But I do think that finishing out my degree would really give me a lot of valuable tools in order to move forward. So you obtain your MD, maybe you go consult, maybe you do research, but I really felt like finishing was in my best interest. And I knew it would take some time. I had about 6.5 months of required rotations left, which didn't seem like a lot to me, seemed doable, but I knew this was probably going to be a process and there was a lot I didn't know about it. 6 months later, maybe it was in December, I reached out to the dean's office and said, hey, I'm really intent on coming back. And I feel like, we've got some lead time. And maybe if I can come back early, maybe I can even participate in the match. And they said, well, great. We'll set up a meeting with you and the disability services office and we can get things going. And so I think it was actually in December and I went on holiday break and thought, great, December passed. We can get to January, can kind of roll up our sleeves and get to work. And I had that meeting not really knowing what to expect. I had a lot of concerns. I think as a learner without a disability, you really don't know what you don't know in medical education. You're kind of reliant on other people to lay out a path of a curriculum, milestones, benchmarks, requirements. And I think, especially with a disability, trying to figure out what those would look like or what reasonable accommodation was something I had a lot of questions about. I didn't have in my mind a roadmap of this is the way we're going to go about it, and we'll conquer it and we'll move on and things will be good. So I entered this meeting and the first question that was asked of me was, well, have you thought about transferring? Which blindsided me a little bit. And I, after some time, said, no, I really haven't. I'm curious what would make you say that. And they just said, well, our mission statement right now is really to create a undifferentiated medical student, and there's a lot of requirements, and it might be easier for you at a different institution. And I said, well, no, I haven't thought about transferring, and I have a very limited amount of time left, and all my social fabric is here to put Humpty Dumpty back together and get me going about my day even. There's a lot of things that need to be set up, and that's really hard to pack up and move and establish somewhere else. And their next comment was just, well, okay, I think we can make this work, but it's probably going to take a while. And my question was, well, how long? And they said, well, maybe a year, maybe more. And to me, I really felt like, boy, I kind of need to get momentum. It's like riding a bike. It's easier not to fall over when you've got a little bit of speed. And I think I felt that sense of urgency of, I really want to push things forward. And that meeting, I don't remember a lot more of the specifics other than it felt like, boy, this is actually going to be maybe harder than I thought.
While it became apparent to Dr. Addison that being allowed to resume his medical education would be more challenging than he had anticipated, he was determined to take the steps necessary to continue with his training. Follow along as Dr. Addison describes how he approached completing his clinical rotations and reflects on the various reservations he was faced with along the way.
At the encouragement of a really great mentor I had had previous to my injury, they just said, you know what, why don't you figure out what the requirements are and maybe think in your mind how you would tackle those, and then figure out who the stakeholders are, figure out who clerkship directors are, figure out who controls the gates, so to speak. And I know gatekeeping is something in medical education that's talked about a lot. And a lot of these things don't happen from the top down, they happen from the bottom up. And the beauty of the internet age, all these clerkships have websites, and clerkship directors have their contact info on them. So I just started sending emails saying, hey, I know you're the clerkship director, and I know that these are the requirements, and I have a lot of ideas on how I could fulfill these with accommodations, and you probably have some ideas, but I want to give you a heads up that I'm intent on finishing, and I'd like to front load this conversation so that it's not surprising to anyone in any way and really find a way forward that's going to work for everyone. And that was a really fruitful move, and it opened up a lot of great conversations. So, just to kind of spell out specifics, I had a neurology rotation, an emergency medicine rotation, and then a chronic care requirement, which could have been palliative, physical medicine, rehab, geriatrics that I had to accomplish. And I think finding time to sit with each clerkship director and brainstorm, how are we going to meet these requirements, and how are we not going to sacrifice the learner education, but also hold ourselves to the standard that, yes, we did the things in the curriculum that we needed to do. That was very positive. And I think that paper that you alluded to with my emergency medicine rotation, as far as examples of maybe how to approach a learner from an administrative or an educator perspective, when I think there's a lot of unknowns. The emergency medicine clerkship director just said, in the ER, we do a lot of creative things. This is something that we should definitely be able to figure out. And I think just having that buy in as a learner, that somebody said, you know what, I'm going to do this. I don't know specifics, but I'm here. We're going to make it work. That made the world a difference for me. And so I made a plan. I got very detailed. I said, okay, I'll back this up with as much evidence as I can. And then I can take it to the disability service office and the dean's office and maybe get the green light that I can go ahead and re-enter medical education. It was interesting because I presented all this, and the response I got back was, well, this is all well and good, but we need to think about it on our end. Things take time, and we'll set up these meetings. And I've heard this experience from a lot of other learners that sometimes the setting up of meetings to get all the stakeholders in the same room or in the same Zoom call, it really takes time. And there's a delay. And I think what was told to me at that point when I was advocating for accelerated timetables, thinking of the upcoming match that summer, was, well, you're so young. It's just a year. If you miss this match, this is a blip. And for me, that just felt so dismissive that I'm thinking about the looming cost of caregiving, the cost of disability, kind of wanting to re-engage with the world, which has so much value aside from the financial aspect of a job, but the way that you view yourself. And for me, I just felt like, man, another year of kind of purgatory in between would just be really, really hard for me. I really wanted to get things going, and it just also felt disingenuous. I think there was a lot of teasing out. There's an Oscar Wilde quote. It's like a sentimentalist is someone who wants the luxury of an emotion without having to pay for it. And it felt a little bit like, okay, a lot of these people are sentimentally happy that Conrad is going back to school. That's heartwarming. That's inspirational. But when it comes to doing the work, okay, now that rubber meets the road, this is a little less sexy. It's a little uglier. How are we going to do it? It kind of felt like people were kicking the can down the road.
That's so
Right.
disheartening to me because I was a DRP and I trained DRPs. And one of the things that I say often in my work and that I find often in my work is that disability resource professionals and the offices that are not trained in medicine actually can be a huge barrier to getting people back into the clinical setting and getting things set up with ease. And I'm so glad that you went directly to your faculty and that they were so receptive to the idea and they were so creative. It makes me sad that you had to take on what amounts to a part-time job to coordinate all of these things when the response should have been yes, and let us coordinate everything as quickly as possible. A year is, as you said, not just the financial, but the social, emotional, psychological. It's taking you away from the thing that gives you passion yet again. And it's so disheartening for me to hear that. And I think that is why the disability person needs to be embedded in the medical school, part of the medical school fabric, so that these things can happen a lot more quickly. I advocate for it being a faculty member, somebody who's working on DEI issues specific to disability, but also who gets the curriculum, understands things, is connected to the clerkship directors who can make this work. And I'm so sorry that you had to do all that work, but I'm also so glad that you didn't get disheartened by the meeting that you had so much that it led you to just sit back and wait on those people, that you actually took control of the situation and reached out. And I can imagine that that was probably a little scary, but perhaps then became empowering when you got the responses that you did.
Definitely. And I would say sometimes it takes a lot of drought to get tumbleweeds moving. It might have even been motivation for me. I mean, that was me re-engaging with the world. Said, great, I'm a border collie. I have a job again. I can push this forward. But it was interesting with disability resources. I think there was a lot of, hey, we have a lot of funding we can throw at this, but you're going to have to give us a 20-point plan on the way that you want to use it. And for me, as I had mentioned, I think I just need room to actually start doing the thing. I think a lot of learners probably feel that. And I've heard it on your podcast before. One of your interviewees that just said, look, give me room to fail. And I feel the same way. And it happens in real time. I think every injury is unique. And obviously, I'm speaking from my experience, and that's not overly generalizable. But I do think so much of this is administrators are nervous, and maybe rightly so. There's a lot of questions. Are we going to put this person through medical school and then they have no viable option afterwards? And we just did the thing to get them their degree. Are we doing them a service? Are we doing ourselves a service? And I think there's a lot of anxiety there. And it felt like my job as a learner to almost shush that anxiety or like console people, like, no, no, it'll be okay, which was very bizarre.
We were talking before we started recording about how the podcast really serves as an educational tool. And I think for these DRPs, the best way that they can support a learner is to understand what's happened before. And experiences that occurred in the past that were successful are one amazing way to get people to calm down, to say, this
Definitely.
is rocket science. Like, this has been done at multiple medical schools, but there was no way to share that information until we built the coalition, which I don't even think started until 2016. But finding a way to share the stories, the successes, and also the failures so we could build on what has already been attempted, with the recognition that people are different, that every injury is different, and that we will need to individualize this to some extent. But going into these places, they tell this funny story about, meeting with 12 administrators that were these
Yeah.
incredible administrators, and they were all worried about the student that was short stature, and how is this person going to engage in the OSCEs, and how are they going to go from room to room? And they couldn't reach the materials, and what would we do? And it was made into this huge mountain. And I had a hard time containing myself through the discussion, but then at the end said, can we go to Walmart and buy a stool for each room? They probably cost $10. Is the simplest solution. And yet people were really anxious about what was going to happen in the clinical space. And I think they were so far back at 20,000 feet that they didn't have the capacity to look at the simplest, most logical answer.
To your point about just kind of knowing things have been done before, I think a lot of physicians think of themselves, maybe they're not scientists, but we kind of think in this way of show me the data, show me the evidence. And data and evidence, it's not immaculate. It comes from somewhere. But I don't think there was a lot of ways to collect it or record it or distribute it for disabled learners. To your point, a lot of these solutions are not challenging. And some of this I would attribute to losing the greater vision. I wish more people in a position of power would think about in terms of educators, administrators, things like that. I think there's things that we suddenly think about for someone with a disability that we don't otherwise. So one of these things for me was being in the ICU and you have contact precautions. And so you've got to put a gown on and gloves on and mask on or face shield or this or that. And one of the things that got brought up to me was, well, how are we going to get you into a patient contact room when your wheelchair wheels are dirty? Are we going to have to sanitize these each time? I think my thought was like, well, most people walk into these rooms with their shoes that are traveling all over the hospital and in the outside world, and we don't make people sanitize their shoes. But suddenly, because a wheelchair is such a foreign object that we haven't thought about in our workspace, are we overthinking it? I think it's just to encourage people to realize that maybe there's things they are going to overthink and try to imagine the real world correlate, like your shoes versus my wheelchair tires, and realize that, okay, maybe this is not something that is that important or going to be that beneficial to do. I think so many accommodation packages, for lack of a better word, are very unique and need to be custom built. And this idea that you can create one maybe as a school or an institution and it's going to be a one size fits all, just do away with that notion. Make things easier for both parties involved. Just being willing to say, hey, we're going to have to think about a lot of things and let's try not to overthink some things or make the easy things harder than they have to and be able to devote our time, energy, financial resources towards those things that really are unique and really are going to add value. I think a lot of this just comes down to how you approach the problem and then how you're willing to react and reiterate in a real time way.
Yeah, I think the most important takeaway message from most of these things has been that when a learner was met with this attitude of, well, we know that you're cognitively qualified, and the rest we can figure out because it is ever changing. And most of it is just being willing to figure it out. There's so many people who have done this at this point that there is data, there are articles, there's a little bit of an underground network to some extent of people who know other people and what did they do. And I work desperately to try to get that all in writing so that it can live on in perpetuity.
Yeah.
But it's doable, I think, is the overarching message. And not only is it, I don't want to say it's like doable to get somebody through. We have the ability to help people thrive as disabled providers in medicine. Why isn't that our goal? When we have these conversations, they tend to focus on risk mitigation, which, of course, obviously, we want safe patient care. But as you so aptly noted, no one that is disabled is going to do something that would put patients in harm's way. I think all of the physicians that I've worked with that have physical disabilities have gone into fields where they don't feel like they'll be asked even to do something that they might not be able to do. And then those fields that have procedural types of activities with them or competencies that they need to be able to meet, they have either decided to limit the scope of their practice or to enter a practice or enter a profession where there are lots of people who can come in and do procedures that they're not able to do.
Yeah. And I think on the other side of that, I would say, in my experience, the learners or those with impairments, maybe myself included, tend to be overcautious. I think there's a lot of learners who maybe sell themselves short, whether it's a career trajectory or asking for an accommodation in a clerkship. They're like, well, let's just not do it. I don't want to put anybody in this position. And maybe there is some value because they're always going to undershoot in having educators who say, okay, well, I understand your concerns, but what if we could? And what would that look like? And are there ways that we could problem solve around that? And so I think that is a useful mindset to have. And that's been very helpful for me.
I think that's so important and valuable because we put limitations on people based on preconceived assumptions. I mean, that's the epitome of stereotyping, right? I look at you, I see your wheelchair, and I decide what you can and can't do without any sort of assessment as to what you actually could do or how we might modify something. Part of the discomfort is just really the internalized ableism of the person deciding that it's uncomfortable. So we have a long way to go, but circling back to kind of what you said about other people doing it, I do think that that's really helpful to tear down the assumptions that medical educators, faculty, administrators can make about what's possible. I always like to use the example of I have a lot of friends that are surgeons, and when you back that up and you realize that these surgeons are all wheelchair users, it causes a lot of cognitive dissonance, I will say, for the average person. And even the average person that's in medicine, I think, has a hard time wrapping their head around that.
Definitely. I would say my own internal ableism. I have an impairment, but there's definitely blind spots I have or things I haven't thought about with regards to other disabilities. And how can we move past that as a field, I think is really important to address.
In the next section, the conversation turns to a case report that Dr. Addison and others had authored describing a particularly creative accommodation he used to complete a required clerkship. Follow along as he and Dr. Meeks discuss the execution of this accommodation model and the pros and cons of involving other learners in this process.
The ER department ended up finding first-year students who had class in the afternoons who could help me on an early shift from like 6 a.m. to 2 p.m. And they could be my hands, my amanuenses, my scribe, which was really a rewarding experience, I think, for everyone. They got time in the ER out of it and exposure to clinical medicine. And I got more relationship with peers. And also, it just really allowed me to do things very efficiently in a busy, chaotic environment. I think about healthcare as a very accessible space, but once you go through those waiting room doors into the back end of things, that changes very rapidly. So there's carts everywhere, there's bins in the halls, there's gurneys, there's wires, there's monitors, and that does kind of present a problem. And so for me in the beginning, as opposed to me trying to fight all that, having somebody with me, I think was actually the most readily accessible accommodation, both for the school and myself. It just made a lot of things easier. And so getting different parts of the exam and learning how to instruct someone else through a lot of maneuvers or instruct them in a way that's going to allow me to get something out of, let's say, kind of a procedural aspect or an exam maneuver. And that's a skill that I'm still trying to refine daily because I do need a lot of help with everything day to day. And if you can find a way to help somebody help you in a way where they don't even realize they're doing it or they're doing it really well, but they don't have to think a lot or have a lot of anxiety. That process started for me in medical school with that accommodation. It's paid dividends as I progressed through training and now in practice. So that was what I would call a smashing success. And that was the article that you had mentioned that we wrote it up on, hey, maybe this is a way that we do this. The ER department found funding to pay them as a job. And I've actually kept in touch with a few of them and they've gone into ER medicine and have all said, boy, that was a really great, rewarding experience.
One of the things that I was curious about was how that experience was for you having other learners serve as the scribes. I could see a model where you have scribes serving as scribes, but they really used this model of having other learners, which I both think is extraordinarily valuable for many reasons, but I wonder if there is drawback, and I could see potential deficits to that model. Can you speak to that?
I think the benefit is for me, this injury was a very alienating experience to the world, I guess. Like, boy, your life looks so different and you look different than your prior self. And what is your relation to everything? And I think it provided a really unique opportunity to me to just say, look, I need help and that's okay. And people were more than willing to do that. And I thought it was a valuable aspect. We used first year medical students and I was a third year, and them getting the time with patients. And then you realize in the short 2 years of medical education, you do learn things that you can maybe pass on and teach to someone else. It also forced me to realize what are important parts to maybe pass on, and it caused me to hone my thinking about charting, etc. I think the drawback sometimes is when you are relying on other learners, they can't unlearn what they've already learned. So maybe they have certain style preferences or things that they think are important, and you run into this tension between them serving as your scribe and them wanting to actively take part in the patient care aspect of things or the medical decision making. And sometimes that can be helpful as far as collaboration, but sometimes it did feel a little bit counterproductive and it becomes a negotiation. You're just trying to document your ideas about medical decision making, which as a third year medical student may not be fully formed. But then when you have somebody else that's chiming in and trying to give input, that at times does make the process more cumbersome, and it is easier to have someone who says, okay, I'm here to scribe, and maybe I turn off my brain in some other aspects of this encounter. But I do think for what we needed to accomplish on that rotation, it ended up being a perfect fit. And them hiring someone to be the scribe and be the amanuensis for that short 6 weeks, I know that would have been its own challenge. So this was a solution that could be deployed on a very short time scale, but that's where I would leave the benefits and drawbacks of that experience.
In our article, we talked about the model of being proximal to someone with a disability and unlearning what your perception is of disability. And it's called contact theory. What I also wondered, though, was there's a fear that I have in contact theory when someone's deemed a helper, that it may, in fact, reduce the impact of being a peer-to-peer relationship. If they're deemed a helper, does it put you right back into the mode of being infantilized, of you can't do this without someone's assistance, and this assistance is then reinforcing this, you actually can't do this?
There is some literature when you look at physician ideas about quality of life in something like spinal cord injury, where most physicians and even physicians who take care of this day in, day out, such as like ICU physicians, etc., tend to think like, oh, that would be a quality of life that would not be acceptable to me. And these are the things I would not want. And they have that luxury of thinking, I get to pick and choose what happens to me in life, which sometimes we do, but often we don't. And I wonder if that comes from a place of you're seeing many people with impairments or disabilities who are having like the worst time of their life in the hospital. And so, in some sense, I think having a helper that is a medical student or part of that medical community gives a chance to say, okay, well, this person isn't a patient in the ICU anymore. They're going on and they're rebuilding their life. And maybe this works better than I thought it would, or there's more meaning in this than I could have imagined. But I do think there is that aspect of infantilization. And it's really interesting concept you bring up of does that reinforce? I would say maybe a little bit, but in that people are able to see like, oh boy, Conrad can take care of just as many patients per day and do these things more efficiently than other people because limitation has driven this innovation. For instance, like charting, orders, workflow, etc. I find that I'm oftentimes faster than other people because I've become very facile with speech recognition or creating things in the electronic medical record and workflows that are going to make my life really easy and really fast where other people get hung up. And so I think for other learners to see that probably actually goes in the other direction and doesn't reinforce that idea about utter dependence and helplessness. And I do think the relationship you build also just solidifies like, oh man, Conrad is a human and you get to know people, you get to know things about people, you build this relationship. And I think in that, people are like, oh, because I want Conrad to succeed, I want other people like Conrad to succeed. So I would say it for the most part is actually more positive than a negative. But I do think that dependence, helplessness, infantilization aspect certainly is a draw and it certainly does exist.
Discussing the preconceived notions about disabilities internalized by medical school faculty and administrators, Dr. Addison and Dr. Meeks further explore the ways in which career counseling may be informed by ableism and stereotypes.
So you wind up matching into internal medicine.
I actually matched into radiology. And actually, the first rotation I did back was radiology, and they were overwhelmingly supportive. And I think so supportive that I thought, boy, maybe I want to do this, not so much because I love radiology, but just the people have been so on board to just problem solve and make things happen. So I actually matched in radiology and I matched in an internal medicine prelim year back in Montana where I had family and I figured I could have a little more support. And part of that too was there was one hospital and a smaller program. And I thought, even though in most people's mind, a town of 200,000 in the middle of Montana is maybe not the most accessible place to be, it actually was more accessible than Seattle in ways that I could get affordable caregiving. I wasn't too far from work. I wasn't navigating traffic. The friction of everyday living was there. So, as a long answer to your question, I had matched in radiology, did the internal medicine prelim year. And that year, I actually decided to not pursue radiology and actually just finish out 2 more years at that same program.
And the program was receptive to that. I mean, it sounds like it was a wonderful experience.
It really was. I interviewed with a program director who actually left right before I started. And I think that can go horribly wrong. I've actually heard that from physical medicine and rehab physician with a spinal cord injury that she matched in a program with a program director who was great. And then they left and things changed and got a lot harder from an accessibility and accommodation standpoint. But this program director had just said, we don't know what this looks like for an intern year, but we're going to make it work. And if there's things we need to do or advocate for, or even if we need to hire a MA or a CNA to kind of be your hand, we can do it, but you just need to communicate with us and we'll communicate with you. And that was actually one of the reasons I chose that intern year was just them being willing to kind of roll with it and give me room to see how things go, but also communicate clearly. And there was a new program director, but they were very receptive. And actually, halfway through the year, we're like, boy, you seem like you like this. I think you're a good fit. If you wanted to do internal medicine, I think we could really make this happen. And we'd have to think about how we do things. But I had kind of found ways to do a lot of things in residency.
So you finish out this residency in this program, a change of pace. And you said you were kind of counseled towards some of these other professions and wound up matching in radiology. Did you think before matching to this particular program for intern year that you were capable of completing an internal medicine
No,
residency?
definitely not.
Yeah.
I had a lot of anxiety actually about, boy, am I even going to be able to complete an intern year? And is that going to be the rate limiting step for me moving forward? Partially just ignorance, not having done an intern year, but partially I do think because of that counseling.
That brings me to a question, and this is one of my big fears, is that people will become accepting of learners in medical education. And even though we have to graduate undifferentiated physicians, that there will be this assumption, this kind of unspoken agreement between the school and the learner that they will go into a non procedural or a specific area of medicine like psychiatry, radiology, et cetera, without really exploring the possibility of all of the areas of specialty the learner could enter. And so I wonder, when you were being counseled about the match and an area of expertise, did people try to counsel you out of certain areas and into some of these less procedural specialties where the assumption of, oh, if you have a disability, you could probably do this, where that is leading?
Definitely. And I think a lot of things that maybe to learners feel hard when they hear, I don't know if they come from a bad place. So I think a lot of educators maybe have this concern like, well, I want you to be successful, and I'm thinking about this and this is the way that I could see you be successful. And they kind of latch onto that. And I maybe did get counseling and I definitely re entered, I guess, on a time scale clinicals pretty quickly. And a lot of adjusting to spinal cord injury kind of has taken me years to really conceptualize what is this? What does it mean? What are the best ways forward? So I was still very much in flux at that time, but I had that chronic care requirement. And I knew some physicians who did physical medicine and rehab with similar impairments. But I just thought, oh man, rehab, they'll get this. Their job is really built around helping people live lives with chronic illness and impairments. And what was told to me is, well, why don't you do the palliative care requirement because it really won't take any navigating or any thoughts or figuring out how to do physical exam. It'll just be so easy. It's just talking to people. And so I do agree. I think there is some counseling, and I had initially thought I would do radiology, and as part of that, you have to do a medicine or a surgical intern year. And I just thought in my mind, like, oh gosh, this is going to be the hardest part, and we just got to get through it and go. And it was interesting because I had a great residency experience. I had a great intern year. And it was so great that it actually made me realize, boy, I really want to be with patients. And, radiology is a great field, but my place isn't there. And I actually could do medicine. And that was something that was never encouraged before. And so I think to your point, I think that really does happen. And I think it's a disservice to waive certain requirements or not put in the work to find an accommodation or a way to give students that experience, like I had, like, oh my gosh, I didn't think this was possible. And I don't think a lot of other people thought this was possible, but it really is. And this would be a great, meaningful career. And I think the opportunity just to do that is immense, and it really can't be understated.
In the next section, Dr. Addison delves deeper into some of the specific accommodations he sought out and utilized throughout his training. Listen or read along as he and Dr. Meeks discuss the diversity of tools he co opted and how the broader public might be made to realize that providing accommodations for disabled trainees and physicians could benefit everyone.
I'm wondering, did you adapt any tools, like any of the otoscope, stethoscope? Did you have to make any adaptation to any of those items or create workarounds?
Yeah. So you'd create workarounds, or I ended up using a lot of hand orthoses like rubber cuffs or Velcro cuffs that could help me facilitate having those in my hand. And I do have a fair amount of shoulder and bicep function where I can manipulate them. It's just the grip portion that's a little bit challenging. And actually, working with an occupational therapy department was very useful. I was still doing therapy immediately preceding going back. And that was something I said, okay, I'm going to have to do these things. I can use this occupational therapy appointment specifically and see if they have ideas about how would I do this and how should I practice. And actually, even things like opening doors or trying to pull a door open and back your wheelchair up at the same time and then get through the door if it's very heavy, which most hospital doors are. Those were things that actually took a lot of practice and a lot of nylon straps and rubber cuffs. And those things were very specific. I don't think there's a lot of a market for adaptive tools in that way. And so you do have to kind of get a little bit creative with zip ties and fabric and finding somebody who can do something and readapt. And I would encourage educators, if there is a way to link in students, maybe with allied health professionals, especially occupational and physical therapy or vocational rehabilitation specialists who have maybe thought about these problems or know individuals with impairments that have done this and done it in a certain way. I had actually heard that, oh, there's a neurologist at Vanderbilt who has a pretty significant impairment and he's got all these great tools and was able to do these things. And so to get into contact with people and see the ways people have approached that, that was very, very useful for me.
I think you've hit on two things that I really try to get folks to do. One is consult with an occupational therapist. OTs are literally a lifeline, I think, to creative interventions that are designed to get people back to work, back to independent living. They're just a wealth of information. And I really encourage disability offices to contract with the OT school at their institutions so that they can expand their repertoire of potential accommodations and understanding access. And then the second thing that you're bringing up is essentially like you were unofficially networking, right? You were gathering information and trying to see who had done it before. What I've tried to do is use crowdsourcing. So use your story, use other stories to inform a collection of information to help people say, okay, here's a list of things that have been successful in the past. How can we apply this to this particular situation? And it sounds like that was really helpful for you. I personally think that attitudes are the biggest barrier that anyone is going to face when it comes to medical education and training. And so it must have been also helpful to be able to say, hey, a doc at Vanderbilt is doing this when communicating with the respective rotations.
Definitely. And I do think that did help with certain worries about how are we going to do this, just to know that, okay, there's someone who's been successfully in practice or at an institution who's done this for some time, and they must have had a way to figure it out. And it's not that we need to replicate that in entirety. It's kind of like, okay, we're not the only ones doing this, I guess, or this isn't completely crazy. That was the take that I got. I think that actually really helped. Looking back on this, I mean, I can't even count the number of physicians or allied health professionals with impairments that I've probably relied on and need to go through and write a thank you card for just saying, hey, thank you for doing this, because just you doing it yourself has created an easier pathway for me. An interesting thing that I think I mentioned earlier, but I'm coming to appreciate more and more, there's never a good time in history to be paralyzed, but I would take now over 30 years ago any day. And I think the amount of advance in technology that's been built for the greater population, but is like so specifically helpful to those with disabilities, really can't be understated. And I think that ranges everything from, let's say, Siri on your phone, touchscreen phones, trackpads on laptops. There's a lot of things where I don't even have to ask for the accommodation because it's already widely adopted by the general public. I think figuring out what those technologies are and how you can leverage them is certainly its own journey, and maybe is very helpful to work with a vocational rehabilitation specialist because they maybe focus more on that technological aspect in a lot of ways. But that has actually really made my life easier.
Yeah, it's pretty remarkable how accessible the world is being made for everybody and how much that's really helping individuals with disabilities. And things that weren't allowed before for people with disabilities, where the accommodation was turned down, are now allowed for everyone all of a sudden. It's like you want to celebrate it, but there's this part of you that's that's also like, are you serious? Years ago this was turned down and now everyone's employing it because it's efficient and effective and helpful, and it's like, well, of course, because it's giving people greater access to do their work.
Well, and it's interesting you say that. One of the things that was said to me early is, okay, well, we have funding for this. It's built into the budget, but I think there's this idea of, well, we really want to use it in a certain way. And so at the time, I think about voice dictation, there was a cloud-based version of Dragon, which the University of Washington was not employing. And I said, this would really make my life easier, because rather than having to fight with the microphone at all these workstations, I could have this portable thing. And it was fairly expensive. At the time, it was a $500 setup fee, and then it was over $100 a month for the subscription. But in my mind, I thought, okay, well, this is expensive, but this would be something to finish out these last few months of medical school that would be very helpful. And trying to get that through to people was actually really challenging, and it never ended up going through. And the pushback I got was, well, we have this old Dragon Millennium edition throughout the hospital, and we just need to find a way to make that work. Now everybody's adopted these cloud based technologies. And just like you said, I think you have a little bit of like, okay, now this is so easy. And I guess I do understand it. There's three sides to every story. There's my side, there's someone else's side, and then there's the truth or the reality of the way it goes. And it is just kind of interesting looking back in hindsight, like, oh yeah, that would have been very helpful. And now it's so easy and no one thinks about it.
I think last time we had talked about some of the easier accommodations as well, the things that just make sense and how people can make them more complex than they actually are. Was there anything that just seemed like a simple solution to you, but was viewed as more complex or multi-layered by the institution?
Yeah, I actually give you an example that came up in residency. and that's this idea of signing paper documents. For me to get a special tool and get a pen and then sign documents is a really challenging thing. And I had a picture of my signature from prior to my injury that I actually turned into a stamp. So in my mind, I'm thinking, oh, if I have to sign these orders in residency from my primary care patients that need, a disability placard or an insurance prior auth, I'll have this stamp. And I actually initially had gotten some pushback where institutions were like, oh, well, we had used stamps in the past, but there's this potential for abuse and maybe there's some legal ramifications and that doesn't fit with our policy. And for me, it was like, okay, well, either I use this stamp or I have somebody write my name, which is not my signature, it's somebody else. And I feel like there's even more potential for abuse in that scenario. But you just think, man, this is such a no brainer. But I think people want to make it much more complicated than it is. And they're worried. And maybe that's a function of our world that sometimes we lose the forest for the trees. Even something like a door opener. In residency, there's conference room where morning report happened, where a lot of educational activities happened that functioned as a workroom for one of the teams. And I went through almost all of residency having to be let into this door because they had to be a certain weight of door that was self-closing that was just really prohibitive to pull open. And so I would have to call people or wait for somebody else to show up to morning report to get into this room. And finally, there was a chief resident who just said, man, we should just get a door opener here. This is a conference room that's actually used for community events, and it's a space that a lot of people use and even probably make it a lot easier for caterers to get food in here. And I think him having the time and energy to advocate for me was huge because, you're in the middle of residency, you're working 60 to 80 hours a week, you're barely able to do your own laundry. It's just one more thing that you say, you know what, I'm not going to fight this. I don't have the time or energy. And I really encourage other learners and residents and everybody up and down the hierarchy. It is really helpful to advocate for each other. That goes beyond disability, but it can make the space A, better for everyone, but B, much more open to those who do have impairments.
Absolutely. And it's funny that it takes somebody to see the bigger picture to say, oh, well, this will help everyone for an accommodation to happen. The door openers, I can't imagine what it must have felt like every day to have to find someone to open a door for you. That just seems ridiculous. And I think in many ways it would make you feel less independent.
Very much so. And there's interesting aspects too, where I think you kind of just say, well, this is the norm and this is the way it is. You just kind of accept it and deal with it and don't realize maybe how much easier it could be because so many of these things get made more difficult than they actually are or need to be. And I think at some point you just reach your capacity and say, okay, well, let's do a threat assessment and figure out which of these things are actually going to derail me and which of these things are a nuisance. But looking back on it, it's like, boy, now that a lot of these have been remedied and I've got a great position now and they're very receptive to door openers or whatever's needed. And I realize that's a lot easier when there's one space where I am each day. I think the unique aspect of being a medical student and being a resident is you rotate in so many different settings in healthcare, and that can be challenging, I can imagine, from an educator standpoint or administration trying to figure out, well, how are we going to create accommodations in these 20 different environments when this learner is only going to be there for 3 to 6 weeks? I don't have a perfect answer to that other than maybe there's portable solutions that can be taken with a learner, and it is okay to actually spend a little bit of money and time, whether that's on physical modification or assistance.
Despite his winding road to an internal medicine residency, Dr. Addison found several allies and supporters along the way who helped make each step of the way more accessible. Follow along as he discusses possible mechanisms for facilitating accommodations in internal medicine and shares his thoughts on the anxieties surrounding the disclosure required to receive them.
The American Board of Internal Medicine provides accommodations. So I wonder, when you went to take the boards, did you become board certified in internal medicine? And if you did you ask for accommodation?
Yeah, and actually, the program director that I interviewed with had been at the Mayo Clinic and then actually is at our internal medicine residency in the Midwest. And his successor had worked with him closely, also came from the Mayo Clinic. And it was really nice to have people who had been in GME for a lot of years because they they know all the fine print. And they had said that to me initially in my prelim year of, oh yeah, here's the accommodations that the American Board of Internal Medicine actually lays out, and here's what you have to do, and here's what you don't have to do. And that was actually part of the reason, like, oh man, maybe this is possible. Like the certifying board has these things. And so to be board eligible, they've got these things. And so I did sit for the boards and I did ask for accommodations. It's interesting. I had to take step 2 clinical skills as well as the clinical knowledge. I was actually scheduled to take those a month after my injury occurred. So I had to postpone. And so I have this accommodations experience of asking for accommodations there. And then with step 3, and then the American Board of Internal Medicine. And it's been interesting for me to realize what I need and what I don't need. But I did get accommodations, and they were very receptive and very agile in providing those and making sure that I was able to sit for boards and do it successfully and have the time and the space and the physical infrastructure that I needed to do that.
I'm so glad we got a little off course and covered this, because I do feel like many individuals, perhaps those that aren't so historically in GME, are not even aware that you can get accommodations and are not even aware really that some of the procedures that you would think would be an absolute for internal medicine don't have to be performed. You just have to understand them and be able to explain them. So when you go to the website for the ABIM, it's really interesting to actually take a look at what is required from a knowledge and translation to patient perspective and what's required from a procedural perspective. And then to know that accommodations are available. And my understanding of the American Board of Internal Medicine is that the accommodations process is pretty easy to navigate. Would that align with your experience?
Very much so. They allow a lot of room for learners to gain different experiences. And I think as physicians, whether you end up in research or a part of clinical medicine, everybody kind of finds their niche. And I think internal medicine as a field, I mean, I think there's, gosh, more than 20 fellowships you can do from it. And maybe because of that, that wide ranging array of paths that people out of residency take, maybe they are more aware of rather than making a lot of these things dictated in terms of procedures, this, that. Maybe we can open that up. And I felt like it was a very easy and friendly experience to navigate. So that was definitely something that made my life a lot easier. And I would say, too, at the USMLE, I was actually counseled like, boy, it's going to be really hard for you to get accommodation. And I don't know if some of that stemmed from maybe familiarity of administrators with students getting accommodation was for things like adult ADHD, that was a new diagnosis, or maybe less than clear cut. And there's maybe some cynicism there. But also credit to the USMLE. I think I sent them a 20-page document of who I am, what my impairment is, what I thought I needed to be successful. And they responded within 2 days and called me, and we had a discussion, and they made it work. They actually provided a amanuensis and a scribe for my clinical skills exam in California and made things about as easy as they could have been and far easier than I would have imagined.
Well, I'm not surprised to hear you say that you were counseled that it would be very difficult. I've had that experience from a lot of learners that have said that they were actually counseled out of even asking for accommodations, which I'm wholly against. I've had a lot of success with the National Board of Medical Educators with all disability categories, but I know that many of my colleagues have really struggled and many learners have really struggled to get accommodations. So I'm really heartened to hear that you had such a good and easy experience. So that's really nice to hear. And I think also something that's really important for our audience to hear is that don't believe everything that people say, right? That
Yeah.
every person's experience can be really different.
I think that to piggyback that, the one thing that comes to mind hearing you say that is actually the concept of disclosure. And I think the risk with accommodations is people get counseled not to ask for them, that maybe you ask for it and maybe they say no. And then you've kind of outed yourself in a way that's, I mean, in chess, it's kind of zugzwang. It's disadvantageous to move in either direction. Now you're kind of stuck. And I do think for people with a physical impairment, and for me especially, I'm not hiding this. I joke with people. They either think I'm the portable X-ray machine, or they know it's Conrad coming down the hall. Like the wheelchair makes noise, kind of announces your presence beforehand. There's just things I can't do, but it's very obvious when people see me. Oh, this is someone with an impairment, and I think we're all approaching salvage value. We all have impairments at some time interval, whether that's in older age or young. And I think a lot of physicians have a change in health status throughout their career. But I think it can be really challenging when maybe there is a hidden disability to want to ask for accommodations or maybe disclose that. I think about something like multiple sclerosis. So relapsing, remitting, maybe it's not as obvious. And maybe if things are going good, you say, things are going good. I'm on the tightrope, but as long as the wind doesn't blow, I'll be okay. And I actually don't want to ask for accommodations or I don't want to disclose this because then it will just create a lot of more work for me, a lot of anxiety from administrators and this and that. And I actually have found it, and obviously this is my experience, so this is not advice, but it's been very empowering to maybe just take control of your own narrative. The only person really qualified to speak to your own experience is you. And I think for me, just being very upfront with kind of both with accommodations, but also just residency, medical school, fellowship to say, hey, here's what I'm pretty positive I can do, and here's what I'm pretty positive I can't do. Obviously, there's exceptions to that, and I'm going to just disclose that. And I feel like that's given me a lot more control over the way things move forward, as opposed to if I just hope that I don't have to do one thing in residency and never disclose that I can't do it. Disclosure is like an insurance policy. It kind of prevents you from further losses. If you don't disclose and then suddenly you do have to do it, then it's like, not only do I have to do the work, but I have to do it in a short amount of time. Whereas having just said, hey, here's the lay of the land and I'm going to be really transparent, I think if something does come up, I've already communicated what a lot of the possible outcomes to this situation would be. I see where it would be a disadvantage to ask for accommodations or disclose, but I think overwhelmingly my experience has been positive enough that even if the reaction you get right off the bat isn't good, I mean, you've started a conversation and it shows you kind of who's involved or who's maybe willing to help you. And it really makes a lot of things clear where I think if you don't ask for things or disclose, there's so much uncertainty. And with that uncertainty, I mean, having to prepare for everything is a lot of mental real estate. And I think kind of shrinking that for learners and educators is in everyone's best interest.
Well, hiding any part of your identity takes up a lot of mental real estate, right? I mean,
Definitely.
not being able to bring your authentic self to a space and to be honest or ask for what you need has to have some sort of psychological impact on the learner as well. I see people struggle to get through. If I can just get through this part of it and without accommodations, then no one has to know that I have a learning disability or no one has to know that I have lupus or whatever the case may be. And I tend to not talk about the law on this podcast because I like for people to be coming to this work from an equal access, social justice lens. But the reality is that if you don't ask for accommodations, accommodations are never retroactive. And so if you find yourself having difficulty of some sort that could lead to you having to do remediation or being suspended or put on a leave of absence, you have no recourse when you haven't disclosed and requested accommodation. And I think that for many program directors or clerkship directors or medical administrators, when students don't disclose and don't ask for help, the overwhelming concern when there is difficulty and it's revealed that there's a disability is that you were not honest and forthcoming and you didn't ask for the tools that you needed to be able to successfully navigate this space. How does this apply to how you're going to practice medicine? And
Definitely.
so there's this trust issue that then is created in that space. And I don't want learners to be in this awkward position where there's distrust on both sides of the aisle.
Definitely. I think we are the amalgam of our experience. I think when we think about medicine, what is the goal? It's to alleviate suffering of others, to take care of people. I think about that from my perspective. They tell you, oh, you should be sitting down with patients every encounter. And for me, that's easy. I think a lot of people we take care of are going through the worst day of their lives or really challenging things. And I kind of laugh because people of a certain generation who say, well, I don't really want a fresh, young, perky, healthy doctor because they just don't understand. And the downside, we can't demand life experience of everyone that they would be wizened and hardened because you got to get medical education done at some point in your life to move on with it. But I think, we all carry these experiences with us and how it allows us to connect with patients who are really going through challenging times, even in the outpatient setting. I think that's so valuable.
As the conversation comes to a close, Dr. Addison imparts some words of advice for those with disabilities who are considering entering the field of medicine. Listen or read along as he encourages students to have the courage to express their needs and calls for administrators to take action for the benefit of their students, even in the face of uncertainty.
One of my favorite poets, Anthony Machado, says, mankind owns four things that are no good at sea: rudder, anchor, oars, and a fear of going down. And not that I can assuage fear, but I think just knowing that you as a learner will provide tremendous value, not only to the system, your peers, your colleagues, your coworkers, but to patient care. Be brave and don't be afraid to ask for help. I think I felt so indebted to people like Peter and a lot of other physicians. I mean, they're too numerous to count, for just having the courage to do it and have done it before. And I think that for me was enough to know that, okay, I don't know what this looks like, but I can do it. So I guess the first thing I would say is know that the outcome is worthwhile, both I hope for learners themselves, but also medicine as a whole. I guess I would say think of accommodations not so much as an outcome, but a process, and one that's probably going to need updating and iterating frequently. And I think if you can open as many lines of communication to as many different people and rile up your base or find your advocacy group, I know that's a lot of effort and it can be exhausting at times. But for me, it's something that's really paid dividends, far exceeding whatever I put into it in terms of other people coming to bat for me in a lot of really profound, powerful ways. And I think the more people you include on your journey, the easier your journey will become. I'm more than happy to talk to anyone. The advice to the administrators I would have is it's okay that maybe we don't have all the answers immediately and that we're going to start a process where we even don't have the answers, because sometimes those answers come just from doing it. I think kind of the friction of movement going forward is often what allows us to say, like, oh, we thought we needed this, but actually here's this way better idea. And here's a way that's going to not only allow you, the learner, a better experience, but we're going to feel like we are meeting these objectives, or we are really able to teach and impart the things that we need to.
I think that's absolutely wonderful advice. And I have really enjoyed getting to talk to you today and getting to know more about you. And thank you so much for offering to chat with those in the pathway or thinking about entering medicine. I think that is so valuable. The podcast is one way that we can provide this kind of asynchronous advice to the learner. But I also think it's really lovely when people can just connect on a human level, chat on the phone, have a Zoom, something of that nature. I know that for Pete, he had people that did that for him, and now he does it for others. And then it's really kind of generational, right? And it's paying it forward for the people who did it for you. So I encourage people to be generous in that space. I know some days it's hard, but I do think it fills your bucket even when you're taking time out of your day to help others. So I really appreciate that. I'm really appreciative of you, Conrad, and thank you so much for coming on today and look forward to chatting with you again.
No, Lisa, it's been delightful, and I'm very appreciative of the work you're doing. Both, I call it gathering the cookbook. There's all these individual things, but are they reproducible? And I think our academic colleagues that are really tackling this work makes it useful for all of us to create that kind of institutional, generational memory, and been an absolute pleasure. So look forward to chatting again.
Dr. Addison, thank you so much for taking the time to share the experiences you faced throughout your training and the insights that you've gained from them. To our audience, thank you so much for joining us. If you enjoyed this discussion, be sure to subscribe to our podcast, check out our previous interviews, and tune in next time. This podcast is a production of the Docs with Disabilities Initiative and is supported, in part, by the University of Michigan Medical School's Department of Family Medicine and Disability Initiative, the Stanford Medicine Alliance for Disability Inclusion and Equity, and the Ford Foundation. The opinions on this podcast do not necessarily reflect those of the hosts, their respective institutions, or the funders. This podcast is released under Creative Commons Attribution Non-Commercial, Non-Derivative License. This episode was produced by Lisa Meeks, Sophia Schlossman, and Nicole Kim, with support from our audio editor, Jacob Feenan.